For the introduction. My name is Wouter Huberts and my background is medical engineering. And as a medical engineer, actually my primary research interest is to develop and apply patient-specific models to support clinical diagnosis and intervention planning. And if we then look to intervention planning, what I actually want to do, or what I'm actually doing during my work, is I consider the patient, I hope the pointer will work, I consider the patient as some kind of dynamical system. And for the dynamical system I can do all kinds of measurements. So I can assess the state of that patient at that point. Then I can use those measurements to develop a patient-specific model. A model that mimics the patient. And then I know if I have a sick patient, I want to have some desired outcome because of my intervention. So I can use my model to modify and evaluate different interventions and predict the outcome of the intervention. And I refer to that as model predictive decision support. And I adapted that terminology from automotive engineering. For example, if they make cars, there's also a predictive model inside the car that predicts what happens with your engine and also changes the performance of your engine. So that's the reason that I'll call that model predictive decision support. Now, most of the models that are developed in dedicated centers are what I call patient-generic models. So that are models that are originally built for understanding physiology, understanding pathophysiology, or evaluating medical devices. But what I now want to do, I really want to move to a patient-specific model. So I want to adapt all model parameters and the boundary conditions to the patient-specific situation. And when we wanted to do that, when I came with my model to the hospital in Maastricht, where I work now, I faced a very big challenge, and that's related to the workshop wherefore we're here now. That is, you need to find a proper balance between model complexity and model uncertainty due to uncertainties in your input parameters. And I adopted the terminology from safety and reliability engineering, so from aerospace engineering actually. And what I use is we can try, the pointer is not working, but we can try to reduce the model framework error. That means I make a model more and more complex so that I come more and more closely to the real system. But the disadvantage of doing that is that also the number of model parameters will increase. And as a consequence, also the uncertainty due to uncertainty in my model parameters. And especially with and especially so model framework error means closer to reality, but that will also increase the uncertainty due to uncertainties in my model input, and especially within a clinical setting, because within our clinical setting most time we only measure once. So we don't have a standard deviation, we don't have a correlation, we don't know the variance. We only have one measurement. So the uncertainties in our model sets, our measurement sets, are quite large. And most of the time also sparse. We cannot measure everything. Because if you're a patient, you don't want to be within our MR scanner for hours. You don't want to be for 5 days a week to come to the hospital to do all the measurements. That's impossible. And also the cost will increase accordingly. So actually we want to find some minimum level of inaccuracy, so be as accurate as possible. And we don't know where we should start with our model complexity. So we have a model from the Eindhoven University or from a technical university, and we are at some point of complexity. Can be less complex, can be more complex. And then we need to find this point. So we need to go iteratively, I believe, to that point. And what's the best point? When do we believe we are at the minimum? When we can use it in the context of use, when we can be useful for the doctor. So that's the idea. Now, to make that possible, to make that possible, we introduced the so-called medical engineering chain. And that chain consists actually of two phases. So you have the preclinical phase and the clinical phase. This is actually what's happening in all dedicated centers on modeling. So you do verification with model experiments, you characterize mechanical properties by biaxial testing, etc. That's actually what is done there. But then you want to bring your model to the clinic. and then you come into the so-called clinical phase. So that's really within the hospitals. And the first thing that you need to address is that your model and also your metric that you want to predict fits into the clinical workflow. I can give an example of that. We developed at Eindhoven University a model in which we were able to predict the post-operative flow after creation of a vascular access that's needed for hemodialysis. Those patients have end-stage renal disease, and the model was based on contrast-enhanced magnetic resonant imaging. But we were not allowed to add contrast agents to those patients because they can die of it. They can develop nephrogenic systemic fibrosis, and then you get really problems with that. So we were not allowed to use contrast agents. So we needed to switch to another modality that was available in the clinics, what they use in their workflow, that was ultrasound. But we were also a little bit penalized because of that, because we only had discrete diameter measurement instead of a continuous measurement of the diameters of the vessel. So otherwise they are not going to use it. So you should always consider, do I fit in the clinical workflow? What's the question of the doctor? Where do they make decisions about? For example, last year was in the Dublin conference, the World Congress of Biomechanics, and there were all kinds of people working on aortic dissections. From a mechanical perspective, as a mechanical engineer, it's quite interesting. But for our vascular surgeon, it's not interesting at all, because they say, we will treat them anyway. So for useful for clinical too, it's not relevant, often not relevant at all. So you should fit within the clinical workflows, to so address the right question. Then, most time, it can be that you need to optimize your model. For example, if you verify a model, a pulse wave propagation model, with pressures and flows traveling along a system, we most time validate that against silicone tubes that are elastic or viscoelastic, but not like our arteries that will remodel. If the voltage increases, my vessel will dilate. So that's sometimes you need model optimization or reduction. But that's the iterative loop I come to. We need model personalization, so we need to decide which model parameters can I measure, which model parameters are most rewarding to measure, should I measure? Because I have only a limited possibility to assess parameters in patients. So you need model personality. In that perspective, I need sensitivity analysis. And of course, you need to do so-called, we call it model corroboration, because I strongly believe that you can never validate a physiological model, because validation means compare it to reality, and that's not what we can do. But what we can do is collect evidence that our model works in the context of use. That's why I call it corroboration. So, for example, if I want to predict a pressure drop or something, I have a model to predict pressure drop, I make it patient specific, and then I have a measure calculated, and I compare it with real invasively measured pressure drops. And then I have an uncertainty in my prediction due to model input uncertainties, and I have a bias. So that's a model framework error. If it's not okay, so I have a too large bias, so my model is not okay, so I need to improve my model. If the uncertainty is too large, I need to improve model personalization. I need to improve my measurement protocol and to get better measurements. And sometimes I need to do both. So iteratively you go until you have a metric that can be used in the clinic. Unfortunately, most of the metrics for which we as engineers believe that they might be useful or might be influential, it's not always the case that that's the only factor. For example, I developed a model to predict postoperative flow after AVF surgery. The postoperative flow was accurate. As an engineer, I was able to predict patient-specifically that postoperative flow, but the postoperative flow is only correlated with the problems associated around those shunts. But there are other factors involved, like diabetes, that I could not address. So always, when you have a metric, you should move on to a randomized clinical trial to really demonstrate that the additional metric that you generate, as accurate as it is, also has real benefit for clinical outcomes. Because most time there's more than that. And I believe that you should go to some kind of hybrid modeling at that point, but that's my personal opinion. Sometimes you're lucky, because sometimes the randomized clinical trial has already been done. As an example, we have the fractional flow reserve. That's a measure to stratify the severity of a coronary artery stenosis. And therefore it was already clinically proven that's useful. But now they use pressure catheters inside the patient, so invasive, to assess those pressures. And Charlie Taylor developed a model here in this part, heart flow, to do it non-invasively by just make a CT scan and calculate it. So that then you're lucky, then you don't need to do that step anymore because they already did it for you. Then, so we have some kind of iterative step. Now, if we then, he wants to connect with Maastricht, but he should do that. And what I need for in this iterative steps, in any phase, model personalization and correlation, I need efficient uncertainty analysis and sensitivity analysis tools. Now, what do I specifically mean with uncertainty analysis? I mean, I have a model, some kind of cardiovascular model. I put in all kind of model parameters that are known with some kind of uncertainty. And I want to know how this propagates to the uncertainty in the output. So that's a forward error propagation actually. And then I can quantify that error, for example, in a metric that is variance. And if you then consider the variance, this circle is the total variance, you are able to apportion each fraction of that uncertainty, so each fraction of that variance, to individual of uncertainty in individual model parameters, or the interaction between those model parameters, or the correlated effect between model parameters. You're able to do that. And this is very important for me because then I can decide which parameters can be fixed within their uncertainty range, so I don't need to measure, and which part I need to measure, are most rewarding to measure more accurately. And that's what I call factor or parameter prioritization. So it can give me guidance on what I should measure and how I should measure them. Now I will focus on the sensitivity analysis. There are several types of sensitivity analysis. The most often used is the local sensitivity analysis, in which you just vary one factor at a time. That's what most people are doing. So you assume that you're around some kind of working point, so that the error is not so big. In clinical practice, I just told you, it's bigger. Another one is the so-called global sensitivity analysis. In that case, you vary all model parameters simultaneously, so you also consider interactions, but can be, and also non-linearities. So if you have models that are non-linear, non-monotonic, or non-additive, most of the time you should focus on global sensitivity analysis. That's the best practice you can do. And surprisingly, recently, I think a few months ago, Andrea Saltelli, who is famous in econometrics and in statistics also and safety engineering on sensitivity analysis, published an article that most people, almost 50%, so 42%, that should have used a local sensitivity analysis didn't do that. So in the field of different engineering fields, so this engineering, so maybe mathematicians are doing that better, but for engineering, almost 50% is doing it in, let's say, not the correct way. Maybe for some applications it can, but now, so better techniques that you can use are the global ones. Now, in global ones you can divide in two methods, so screening methods and so-called variance-based methods. Now, the screening methods are actually methods in which you can very quickly do a pre-screening, and you can find out which model parameters are irrelevant. So not relevant, but irrelevant. So the stratification, the ranking for relevant parameters is not so clear, but you can make it irrelevant. That's the famous Morris method. So I can use it for parameter fixing. I can find out which is completely irrelevant. But it's fast, relatively fast compared to other methods. The gold standard at this moment is the so-called variance-based method. And the variance-based method is I can use it for fixing and for prioritization. And you can calculate all the metrics, which I will explain later, with all kinds of methods. You have the Fourier amplitude sensitivity test. It's a frequency domain analysis to find out which are the important parameters. You have generalized polynomial Gauss expansion. You have the adaptive generalized polynomial Gauss expansion, and you have the gold standard, the Saltelli method, what is an efficient Monte Carlo approach actually. And you also have, that's what the group from Allison Marsden is quite often used, you also have a Lagrange interpolation method to calculate those indices. But I will now focus on the generalized polynomial Gauss expansion and what the polynomial Gauss expansion method is, because in our experience that was for us the best alternative. But first, what's the variance-based method? Now, the variance-based method I explicitly or implicitly introduced it already. If we consider the total output variance to be a circle of unit area 1. You can apportion each fraction of this circle to either a single model parameter, so to model parameter 1, to model parameter 2, or model parameter 3. That's what we call the so-called main effects. So that's the contribution of that parameter alone. And we have so-called interaction effects. So you can stratify the interaction between model parameter 1, 2, 2, 3, 1, 2, 3, and 1, 2, 3. This is what they call the Sobol decomposition. So that's what we use. Now then you have two indices that are most often calculated. The so-called main effect is given by this equation. So the variance of the expected value of my output I given xi, and then scaled with the total variance. That's the main index. You can look at it a little bit like this. Let's consider this as the output response. This is my input, and I run multiple simulations, so I get all kinds of scatter here, and it follows this relation because it should follow the physical relation that's behind it. Then you can say, okay, let's fix it at this point, xi star. Then this is the mean or the expected value of all the points that are along this line. So I have the expected value, and I do it on all different points. So I have a variance in expected values. So in this case, there are a lot of different means, a lot of variance in the expected value. Well, when it would have been a straight line, my variance would be 0, so also the impact Si would be 0. That's how this index is defined. And you can interpret it as the expected reductions in variance if the exact value of xi would have been known. So this can guide me, if there's a very high value, it can guide me what is most rewarding to measure more accurately. Now you can also assess higher order effects, so then you can calculate the V12, the V123, but most of the time that's not done because that takes too much calculation time. With the Gale's expansion method we can do that, but what most people are calculating additionally to this, so I only now calculated those fractions, I can also calculate those, so I can also find the interaction, but to reduce the computational cost, most of the people calculate the so-called total effect. And the total effect is just the sum, for the total effect for parameter 1 is its individual effect plus all the effects in which he is involved in interactions. That's the total effect. And you can interpret this as the expected variance that's left if all factors except xi are exactly known. So if xi is very important, this value should be high, and you can not fix it within this uncertainty domain. When this value is low, you can fix it. You can say, okay, make it a constant within the uncertainty domain that I know. So that is the variance-based method. Now then you can calculate those metrics. You can calculate this in different methods. One of the methods is to use so-called intrusive methods. In that case, you need to introduce the polynomial chaos expansion, so stochasticity, inside your numerical modeling code. So every time you have another model, you need to rewrite your code. As I'm a medical engineer and looking to multiple applications from the brain to down to the legs and the tooth and everything, I don't want to use intrusive methods. So I use so-called non-intrusive methods. That means, that's the penalty that I get, I need to evaluate the model multiple times. So I create randomly samples within the input space, I run my model multiple times, and I get multiple outputs. For now it's our scalars, but it can also be vectors and also multiple locations. And then I use a so-called meta-modeling approach, because the general polynomial is actually a meta-modeling approach, and then I can calculate based on that directly, analytically, when I have the meta-model with polynomial Gale's expansion, I directly have all the indices. So not only main, not only total, but also all the interaction effects I can get out of it. Now, just a basic idea of the meta-model, I think most of you are familiar with that, but the idea of the meta-model, let's consider this simple model. I have a model with output Z, which consists of the zeroth order Legendre polynomial plus the multiplication of the first order Legendre polynomial as function of x and I, so that's my input parameter, plus the third order polynomial of the Legendre polynomial. I take this example because in polynomial Gale's expansion with uniform distributions, I will also use Legendre polynomial, so I can demonstrate that our method works. Now then I run multiple times, so all the red dots are multiple simulations, and then I fit some kind of, let's say, response curve or meta model through it. That's actually the basic idea. Now, when you use as meta model the polynomial chaos expansion, what you're actually doing is that you span the stochastic output space by multivariate polynomials in which all the variables are random, so stochastic. That's the idea. So for example, I have my output, this is my model, and I approximate it with expansion coefficients and all kinds of polynomials of 0 order, first order, second order, till the pth order of that. Then you a priori need to select which kind of basis polynomials you use. If you use a uniform distribution, you take Legendre polynomials. So that's actually what I will now do for now. Then you need to decide on which point you truncate it. So I can say a priori I go to second order, or I go to third order, or I go to first order. So you need to make an a priori estimate. Now I will introduce a slightly different notation. My notation is now, so the coefficient will be gamma, and my polynomials will be psi, indicated with a multi-index, and this psi is the product of univariate polynomials of the order ai, so of the element of my multi-index, times xi. Now just to be a little bit quicker, because I think I'm running a little bit out of time, there are some constraints on the multi-indices. These are the number of basis functions that you will get if you make some kind of selection. If I select a maximum polynomial order of 2, with 2 model parameters, I end up with 6 basis functions, and I need 12 simulations to calculate those. Now, what you then get is that you get a multi-index, so 0, 0, 1, 0, till 0, 2. So all possibilities of multi-indices that have indices larger than 0, that are integers, and the sum of those should be lower than the maximum polynomial order than I select. And here you see that it is a product, so I take the 0 order polynomial of x1, that's 1, times the 0 order polynomial of x2, that's also 1, so I end up with 1. And so I can derive all the basis functions, assuming Legendre polynomials in this case. Yeah? Now then, the only thing that I don't know are the coefficients. Now there are several methods to do that. You have spectral methods and regression methods. We use regression method because they seem to be more suitable for our applications. And so that's the reason that we did it. And if you now have those coefficients, you can directly assess, because the expected values of the polynomial, it's an analytical function, I know it on forehand. So as soon as I have the coefficients, I can calculate all metrics directly. That's actually the basic idea. And now in the last part, so I'm almost finished, I will focus on the so-called adaptive polynomial. So let's reconsider our simple example. If I now would a priori select that I would go to maximum third order, then all those dots would be the basis functions that I need to include. So here I have all the 0 order in x1 and 0 order in x2, first order in x1 and first order in x2. But actually, if you look to this model, at the end I should only end up with this one, and this one. So I have a lot of redundant basis functions in there. So why should we not create a meta model step by step? Because that can reduce, so only include those basis functions that are relevant. Now that was introduced by Blatman et al. In reliability engineering and was adopted by one of our PhD students a few months ago. Now how does that work, that basic idea? Now let's see, we have some runs. So a priori selection, we did multiple runs of our model. Then we say, okay, let's fit the average. So the 0th order, I add that to my model. Then I use some kind of leave one out method to predict, if I fit it through all points except one, am I able to predict that one? And then I leave out that point and see if I am able to predict another one. And then you see that it's not so perfect, because with this model I cannot predict those points correctly. So I will add first the terms that are relevant, so the blue ones, of first order. So this one is irrelevant and only this one is relevant. So that's why you see here the linear slope. And then I do a backward step and remove those that are irrelevant. Then I do a forward step, adding all the second order polynomials. I do a backward step and remove the irrelevant ones. And I can do that step by step. And then at some point, at the final step, I end up with this model. Now, then we apply this to, for example, an abdominal aneurysm, and that's the last example, and then I'm ready. That is, we have a wall thickness, we have a diameter, we have boundary conditions that can all be uncertain, we have a pressure loading that can be uncertain, and such a calculation takes a few hours. So we want to run it multiple times and we don't want to wait too long. So we applied our polynomial chaos expansion method. And here you see the predictive value of our meta model as function of the number of model evaluation. This would be the quality and the number of runs that I need if I use the normal a priori selected generalized polynomial chaos expansion method. But you see that we can already reach a quite good quality meta model much earlier. And why do you see all the different points? That's because if you want to do the adaptive polynomial chaos, you have some settings. So when do you accept a polynomial as accurate? So you have some settings, and we did some Monte Carlo evaluation to assess the best settings. So you can do that, and that is negligible compared to the runs of your real model. Now then we found that if you compare it, we only needed 26 runs to get the full sensitivity analysis. If we use the Saltelli method, so the gold standard, we needed to use more than 6,000 runs, so it's a significant reduction compared to the gold standard. Now, we also applied to another model, but I will skip that because of time. I will now continue to our conclusions. What we actually found out is that the polynomial chaos expansion is an accurate manner, of an accurate way to do uncertainty quantification and sensitivity analysis. We like the regression approach more than the spectral one, especially when we had a lot of model parameters. You can reduce the cost by adaptively building the meta model. You can also do a parameter reduction via pre-screening. That's also something we did. We had a model with 100 model parameters. We did a pre-screening, reduce the input space to only 10 relevant ones, and then apply to general polynomial chaos expansion. And you also get a significant increase in speed. Now the challenges, what are the open challenges at this moment? Now one is of course, how do we deal with dependent model parameters if you cannot put it in a physical relation? How are you going to deal with that? Recently some authors published on that. They use the same metrics, so they use the main effect and the total effect, but the connotation of those metrics are different, and also the way you need to calculate that. So you can stratify between a total uncorrelated contribution and a total correlated contribution. So you can extend this model easily, between brackets, to dependent parameters. And the other thing is, how can we further reduce the computational cost? And then you can, for example, think about creating an emulator, a Kriging model or a Gaussian model to make a model of your model and then apply our sensitivity analysis tools on that model. So that's actually what I wanted to tell you from an application perspective, let's say it like that. So, are there any questions?
Thank you very much, Wouter, for this clear presentation. I have questions from the audience.
So I think that how you differentiate between the polynomial expansion chaos and the generalized polynomial expansion chaos? Like, how did you decide to use one of those?
Yeah, actually, the polynomial chaos expansion was developed within mechanical engineering, and it always assumes that you had Gaussian distribution, so it was always based on Hermite polynomials. That's polynomial chaos. Then people say, okay, if you use other distributions, you should use other polynomials. So you should, for example, uniform distribution, you should Legendre. Then they call it the generalized polynomial chaos expansion method. And that's what we decided to use, because in the clinic, most of the time we only have one measurement. So the best thing we can do is make a conservative estimate about the 100% uncertainty interval that's there. What you also do with the measurement, if you only have one measurement, you can be sure that this table is between 10 and 50 meters. So it's quite large then, but the uncertainty will also be larger. But because we want to make a clinical decision, we can better have a too large uncertainty interval than make it too small, that we are going to make wrong decisions. Then we can better be a little bit more conservative. So that's the difference.
Other questions? If not, then I think that we should close this session, which gives us time for the lunch, which is at Westminster College. You have got a route to that college. It takes about 10 to 15 minutes to come there, and we reconvene here at 2 o'clock. Okay, thank you very much.